Hindi,
Hey Rishi,
Hi,
uh, meet you in person,
good to see
kind
you
of.
as well.
Very much appreciate you coming on and doing this.
Of course, I just happy to do it. I've been hearing about you guys from Justin Richards for a very long time now, so it's good to finally connect.
Yeah, absolutely. Um, Before a lot of people get on, what I found a lot of different titles for you on the Maryland site and shock trauma site. So, what would you like me to say in terms of an intro?
Uh, Chief of Vascular Trauma, how's that?
Got it. I'll leave it simple and to the point. That sounds perfect. Um, and it looks like Aaron's on. So, Aaron, we're recording already. It looks like.
We're recording already.
Perfect. Yeah, and we'll post this on our YouTube channel as long as you're okay with that.
I
Uh,
am. I'm fine.
Perfect. Perfect. Yeah, it seems to be going pretty well, and it's definitely expanded our reach a little bit.
That's
So
great.
we went, I think we tripled our membership or subscribers from one to three pretty quickly when we started to do it. So
That's pretty massive growth, man. Just make sure you don't forget who you are and remember what's important.
yeah, um, a very underutilized resource we had. I was told with the trauma anesthesia societies. So, well, we'll give it a couple minutes. I will say, I don't think anything I've ever posted with this in 3 years has gotten as much attention as this has, in terms of the number of people that said they're interested and are going to attend this. So I'm very intrigued at how many people actually show up. We normally get about 20 to 30 people, and I think 60 said they were coming.
Good Lord. Okay.
No
No, you
pressure.
should not have told me that.
I was thrilled. I was like, all right, we finally got something that people are excited about. I've only been after this talk for 3 years, like someone to talk about REBOA. So
Well, I think that it's a good time to talk about it just because I mean, you'll see if you
yeah,
haven't looked at the presentation already, I do talk about that paper in JAMA, which is a terrible paper.
hey, this is perfect. I love. I won't say controversy as much as I love things that we all like. It's like cultural things about where we practice, and this is why we do it the way we do it, and there isn't necessarily a right reason. And, it's like, this is a great one. Our next one next month is on, lactates and orthopedics. And it's like, something where, I don't know, it's very center specific. And I think it'll be really good to hear about other people and what other centers do. And we all will learn from it. So,
It's funny, Justin. I'm not going to go into this during the talk, but we have this partial REBOA catheter that's been rolled out to a handful of centers. And so once a month, maybe twice a month, I'm on these conference calls with these other centers. And what's really striking is how different our practice patterns are. Like
yeah,
there are people like Grady who are getting REBOA catheters that we would never even think of putting them in.
yeah,
And for different reasons.
yeah.
They're so busy that they will put a REBOA up to temporize while they, get an OR ready or get a patient out of an OR. Um, there's a place up in Toronto, St. Michael's, which uses it because they don't have a lot of blood in-house.
Yeah.
So they kind of draw out the resuscitation with a REBOA.
I see that's the part that to me is so fascinating is, we learn how to practice in the environment we're in using the resources we have. And it's, thinking a little bit outside the box and saying, what am I trying to actually accomplish? Not maybe what the literature tells me I should accomplish, but what am I really trying to do here? And using all the tools you got at your fingertips to do it. So
Yeah, I mean that ends up being the subject of the latter half of my talk. So I'm sure that we as a group can get around to talking about that too. But It's really important. Justin says that he's going to be a few minutes late, so I'm not supposed to start making fun of him.
Okay, at least until he's here to defend himself. That's great. Um, we normally give it a couple minutes, but the fact that we already have 18 people on is this is like a new record. And I already see it. What's great is I see I think at least 4 different centers represented, so I'm very happy about that too. We're really trying to expand this and get more people and more centers interested in just talking about this. So actually, if you're okay, I'm okay getting started.
Sure.
Okay.
Yeah, do it.
Well, thank you guys all for coming. I know more people are coming on like every minute. But thank you for joining us for another multidisciplinary trauma conference. Today, we are very fortunate to have Dr. Rishi Kundi from Shock Trauma. He is Chief of Vascular Trauma there. And he is here to talk about something I've been dying to hear about for years and to get someone on this to talk about, and that is REBOA. We've had some people in the past that said, yeah, I'll come in and talk about it. Then they leave here. Or they leave the center that they're at and we lose contact. And, you know, I really, this is a great opportunity for us to get a good, you know, objective view of it. And especially from here at WashU, where we do not use this a lot, to hear about a place that does use it and someone that has a lot of experience with it. So with that, I'll let Dr. Kunde start talking. This will be posted on our YouTube channel at the end of the talk. We are giving out CME. We are still advising how to get it from the YouTube channel, but please sign in with your name so that we sign you up and register you for the CME. If you guys have any recommendations for talks, I'm still creating the rest of the year, and I'm always interested in ideas or topics that people want to hear about. So with that, the floor is all yours.
All right, thank you, Justin. So before I start talking, let's see if I can do the usual thing. And can everyone see my slide?
That looks great.
Okay. Let's do this there, and everyone can hear me, I assume. I hope.
Yep, all good.
Loud and clear.
Okay. All right. So, good evening. I want to thank you all for inviting me to speak. As Justin said, my name is Rishi Kundi. I am a vascular surgeon and trauma surgeon at the Adams Colley Shock Trauma Center at the University of Maryland. So before the substantive portion of my talk, I want to give you some context for what you're about to hear, because I think it's actually important. I completed all of my training initially in New York. I did general surgery my lab years and my vascular fellowship, and I took my first attending job at the University of Maryland in the Division of Vascular Surgery. And right about when I was going to start as a faculty member, my chief gave me a heads up that one of my fellows that I was about to, become faculty for was actually a very well-known trauma surgeon who was pursuing more training. Her name was Megan Brenner. I was a vascular attending purely vascular for 5 years. And over the course of those 5 years, Megan Brenner and one of my vascular partners, Melanie Hain, were getting the endovascular trauma service up and running at the Shock Trauma Center. This is why Megan went back to vascular fellowship. They would be on call most of the time, but I would help out 1 or 2 weekends a month. And very quickly, it became one of my favorite parts of the job. One night, I got called in to embolize a pelvis, and afterwards, I actually I'm sorry?
Oh, I think it was just someone needs to mute. So just a reminder, if you're coming on, please mute your microphones.
All right. So one night I got called in to embolize a pelvis, and while I was there, I actually helped Deb Stein with an X-lap she was doing because there were a number of rooms going at once. And a couple of days later, I just decided that it was time to go back for a critical care fellowship, and I've been at Shock ever since. So every month, I will spend 1 to 2 weeks on a trauma service as a trauma surgeon, and then 2 weeks on the vascular trauma service. We have 3 dual-trained vascular trauma surgeons, each of whom does both trauma and vascular trauma. So you have some perspective, some idea of my perspective, rather, when I'm talking about REBOA, which, for those of you who aren't aware, stands for resuscitative balloon occlusion of the aorta. It is, and I am not simplifying this in any way, an intravascular balloon catheter that is threaded into the aorta and then blown up to block the vessel. The balloon can be deployed in the descending thoracic aorta, or zone 1, or in the aortic bifurcation, zone 3. In the descending thoracic aorta, occlusion can mitigate distal arterial bleeding or maximize coronary and cerebral perfusion while resuscitative measures are ongoing. In zone 3, aortic occlusion can minimize pelvic or junctional arterial bleeding. That's it. That's what the big deal is about. And this is why being a vascular surgeon kind of changes my perspective on this. It's kind of just a balloon. One of the more frustrating parts of this conversation for me has been the assumption that I am a REBOA advocate because I'm part of the Shock Trauma Center. And that's very, very indicative of the tone of the discussion around REBOA over the last few years. You're apparently either an advocate of REBOA and think it's going to save everyone who's bleeding to death, or you think it's completely ridiculous and it's killing people. And there's no nuance or complexity, which seems to be a running theme of our society in general. The discussion has gotten so contentious that one of the primary REBOA critics, Bilal Joseph, presented an abstract at last year's Western Trauma meeting that associated authors' financial relationships with REBOA catheter manufacturers and the likelihood that their paper was in support of REBOA. He was essentially claiming that anyone who published evidence in favor of REBOA did so because they were being bribed to do so by industry. The response to that was about what you would expect, and he toned it down significantly when it came time to actually publish a paper. And so, like I said, this is why being a vascular surgeon is relevant. I don't know what other people consider REBOA, if it's a metonym for the idea of aortic occlusion or for the concept of a REBOA service, but to me, it's just a balloon. It's a physical object. And in that light, this furor is kind of stupid. Imagine if the same discussion was being had over another instrument, that articles were flying around claiming that a cryol clamp was the secret to preventing hemorrhagic death, or that anyone who uses a cryol was hurting a patient. In that context, it's almost self-evident that it's not the instrument, it's how and when the instrument is being used. In the case of REBOA, that question, how and when, is particularly pointed. Aortic occlusion isn't a new technique. But with a REBOA, you don't need to do a thoracotomy or a laparotomy to occlude the aorta. You just need femoral arterial access. And that's drastically altered the time, complexity, and morbidity of aortic occlusion, and that in turn has put us in a position of uncertainty. This is a point worth repeating. It's not the physiologic effect that's new and mysterious. It's the ease and complexity of getting there. And we've seen this before, when coronary revascularization went from the cardiac ORs to the cath lab, or when a FEMPOP could be replaced with an outpatient stenting. It forces reconsideration of who should get this, who should be doing it, and where it should be done. Everything changes. To use a chemistry metaphor, when you drop the activation energy for a known reaction, when you add a catalyst, you don't just get more product faster. You change the equilibrium. You end up with unanticipated intermediate products, and occasionally you blow things up. To give you an idea of how intuitive an idea this is, here's the first published REBOA case report. It's 1954 out of Korea. And you can see that quote, "Everyone is familiar with the practice of manually compressing the exposed aorta for a period of time to control hemorrhage or to combat a hypotensive state during laparotomy. To accomplish this same result in the unexposed aorta, a balloon catheter was tested in an intra-aortic tamponade in 2 critically injured Korean casualties." That is word for word what I would use to introduce the same topic today with the current technology, with the current state of knowledge. Nothing has changed. In fact, when I look at that picture, I do know that it's not a modern REBOA catheter, and the only reason I know, is because that's a glass syringe. The catheter itself is trivially different from the ones we use today. Dr. Hughes' paper discusses 2 patients, and it's usually mentioned in every REBOA discussion, but I'm actually more interested by a paper I don't hear mentioned as often. In 1989, Jerry Shaftan published his group's 5-year experience in an organized effort to use intra-aortic balloon occlusion in penetrating abdominal trauma. This is the first case series looking at REBOA in penetrating trauma in general. He looked at 3 groups: REBOA that was placed in arresting patients in the ED, in hypotensive patients in the ED, and those patients who crashed intraoperatively and needed intraoperative aortic occlusion. All the patients who had no blood pressure died on the table. 1 died as soon as they transferred her to the table, but the other 4 achieved a systolic of at least 80, which was enough to start surgery. In group 2, 2 patients died on the table, and both of them had cable injuries, which REBOA was not going to address. 1 died on post-op day 3 of multiple organ failure. That is something that's going to come up again. Everyone in group 3 went into the AOR with a systolic of at least 80, crashed during the case, and then regained a systolic of at least 80 after REBOA. 3 of those patients died on the table, and they all had either cable or portal venous injuries, which would not be helped by balloon occlusion of the aorta. 3 died later, 1 3 months later, but the other 4 survived to discharge. The catheter that Dr. Shaftan used was a precluder, a purpose-built aortic occlusion balloon. While he was in New York building up his numbers, Dr. Ronald Lowe in Oklahoma was using it on patients outside of trauma. In 1986, 3 years before Dr. Shaftan, he published his results. He used it in 15 trauma patients, 5 AAA ruptures, 2 patients who were just found down and hypotensive, and 1 with a massive GI bleed. 2 of the trauma patients survived to discharge, and each of them had an occlusion time of less than half an hour. 1 died several days later with multi-organ failure, and Dr. Lowe made sure to note that they had undergone aortic occlusion of more than an hour and a half. In fact, he specifically mentions that under any circumstances, ischemic damage to the kidneys and spinal cord becomes likely after 30 minutes of complete uninterrupted occlusion. Bear in mind, this is 1986. This is going to come up again. He also mentions, by the way, recently we have started to place small femoral catheters into potential patients so that if deterioration occurs, the artery will already be cannulated. This is a practice done by his group, again, almost 40 years ago. The late Roy Greenberg in 2000 described 3 ruptured AAAs that were temporized with balloon occlusion and repaired with the physician-created graft. Juan Prodi had described EVAR 10 years earlier, but endovascular repair of ruptures was still relatively unheard of in 2000. All 3 of these patients were repaired successfully with balloon occlusion of the descending thoracic aorta. You can see from these scan images, these were not well-contained ruptures by any means. In fact, the increased prevalence of EVAR is responsible for at least some of the interest in REBOA historically, not because balloon occlusion was becoming standard for ruptures by any means, but because the final step in EVAR requires a modeling balloon to seal the endograft against the sides of the aorta, which meant in turn that every hospital that performed EVAR was equipped with a REBOA catheter, whether they knew it or not. This model here, the CODA, is the occlusion balloon that became synonymous with REBOA in the early literature. One of the reasons that REBOA attracts so much attention is that it is, or it's touted as, a solution to the problem of non-compressible truncal hemorrhage. The top 3 etiologies of traumatic death among civilians are brain injury, hemorrhage, and sepsis multi-organ dysfunction, and I think a substantial portion of the last is composed of the delayed effects of prolonged hemorrhagic shock at presentation. In 2007, Teixeira at USC looked at more than 35,000 consecutive admissions to LA County. He found that while only a small proportion of total in-hospital deaths were preventable, 2.5%, the most common cause of these deaths was hemorrhage. More tellingly, most of these preventable deaths occurred early in the initial resuscitation stage. Efforts in pre-hospital care to control extremity hemorrhage through widespread tourniquet training and a restructuring of ATLS priorities have given us well-publicized means of controlling bleeding from the limbs, but non-compressible truncal hemorrhage remains an area of substantial potential improvement. So here we are. We have an instrument that makes intuitive sense and that replicates a known technique. We have a recognized area of potential improvement. We have a need. And as with any surgical technique, we have a handful of surgeons who did it just as a last resort, and they just published their experiences. What questions do we need to ask to know in an era of evidence-based medicine that this works? Animal models, of course. This is the typical surgical kind of progression where a surgeon just does it in people and it seems to work. So then we begin studying it in a systematic way, starting with animals. Todd Rasmussen in the military led the way with these experiments. In a swine model of iliac arterial injury, zone 3 REBOA resulted in profoundly less mortality than packing or doing nothing, and with a substantial increase in mean aortic pressure, particularly if the animals were made coagulopathic. Using the same model, he looked at zone 1 REBOA in hemorrhagic shock, exsanguinated pigs, but not actively bleeding, and found that REBOA inflation continued to increase aortic pressure as well as cerebral oxygenation. In this model, the animals were allowed to hemorrhage for 20 minutes, at which point a REBOA was inflated for either 30 or 90 minutes. Then resuscitation began. It's interesting that both the REBOA and control groups could be resuscitated to similar aortic pressures after the REBOA is deflated. The differences in cerebral oxygenation persisted up to 48 hours after injury. They also found that after 90 minutes of REBOA occlusion, there was a substantially higher rate of kidney injury and liver necrosis than seen after 30 minutes. This limit, again, 30 minutes, is now generally accepted as the safe limit of occlusion. Remember, this is what Lowe had said 27 years before. The same year and in the same laboratory, Zone 1 REBOA was examined in actively bleeding animals, as opposed to animals who were just made hypovolemic. They were subjected to liver and spleen injury, allowed to just bleed for 10 minutes, and then randomized to REBOA occlusion, nothing, or partial REBOA for an hour. I'm absolutely not going to talk about partial REBOA right now. It's a presentation all to itself. Then the animals underwent damage control surgery. It was meant as a representation of traumatic hemorrhage in humans and the so-called golden hour. Obviously, all of the patients who got nothing just died in the first hour after injury. About 10% of the REBOA animals died during the free bleeding portion. After that, only another 15% died between hours 4 and 5 after injury. The other measures of perfusion were persistently better in the REBOA group, even after the balloon had been deflated, which is not really that surprising because all of the control animals had been dead a while. This animal work demonstrates pretty convincing physiologic effects of REBOA. Other surgeons around the world must have found it convincing as well, because enough had used and published on REBOA that in humans that a 2016 systematic review managed to include 41 articles about the technique. Most of them are case reports, some are case series, and a handful of are cohort studies. One is a review of the Japanese National Trauma Data Bank. Most of them looked at prophylactic REBOA before planned surgery. Results regarding mortality were mixed and resulted in no clear solution. The most conclusive finding was, and we've seen this going all the way back, that there was an increase in systolic blood pressure. 2 years later, another meta-analysis looked specifically at REBOA in the context of matrix segmentation control for both traumatic and non-traumatic indications. In trauma, there did seem to be a survival benefit. And once again, REBOA showed a significant increase in systolic blood pressure, a mean of about 80 millimeters of mercury when inflated. The discussion highlighted a point that will reappear throughout all of these studies. Nobody knew how REBOA was being used. As the authors stated, in most studies, it was unclear whether REBOA was used in the context of a formal damage control protocol with consistent application, or whether it was used as a last-ditch effort to salvage in-hospital patients who are anticipated to have impending and favorable outcome. For this reason, the Japanese Trauma Data Bank study, had to be excluded from the meta-analysis. It's worth mentioning that a few years later, another study from the same database used propensity score matching, which had not been used prior, and found that there was a substantial survival benefit to patients undergoing REBOA. As far back as the Shaftan and Lowe papers, emergency REBOA was explicitly used for patients who were declared moribund. Even the Hughes paper, the first one, says something to the effect of, we had no other option, these patients were going to die, so we thought, man, why don't we try this? The problem with this, of course, is that terms like moribund and we have no other option are really subjective, and they change with time and location. When I was a resident, my surgical ICU attending told me about a particular patient that I was in the wrong for attempting to resuscitate a patient from a pH of 6.9 because a pH of 6.9 was unrecoverable and efforts were futile. And even then, that was far from a universally held opinion. But if we were using REBOA in patients who are universally recognized as moribund, we would be just putting them up in cadavers. But what if we compared REBOA to something else that we regard as a last resort, something that we also do in patients who are regarded as moribund and when we have no other good option, something where that decision automatically incorporates the judgment of the person at the patient's bedside? There's certainly some algorithms for aortic cross-clamping, but there is a similar kind of subjective surgeon judgment when it comes to cracking the chest. In 2013, the AAST created the aorta database to track aortic occlusion by any method, and this was one of the first questions addressed by the registry in 2018 and again in 2023. Even 5 years after the database was founded, it was clear that it was going to be extremely difficult to compare the two in an observational manner. The REBOA patients were rarely penetrating traumas and were less likely to have come in with ongoing CPR than the patients who ended up getting thoracotomies. Interestingly, the post-occlusion systolic was much higher with REBOA, and aortic occlusion was kept going much longer with those patients too. A greater proportion went on to have a binder placed, their pelvis embolized, or an XLAP performed. They needed more blood product, but they had a smaller base deficit. They had less severe acidemia and a lower mortality. But given the differences in patient populations, it's really hard to interpret REBOA as an important factor in any of these. So let's just look at the patients who didn't get CPR. Now we're getting a hint about how the presence of REBOA as an option changes management. Patients who never got CPR but did get REBOA had a mean systolic of 64 and a mean heart rate of 106. Those who got thoracotomies but no CPR had no blood pressure on average and a heart rate of 12. This is what I meant about the ease and complexity of the procedure. People were still waiting until the patients were about to arrest to do a thoracotomy, but there was something about REBOA that made it easier to pull that trigger. By 2023, there were 3 times as many patients in the aorta database, and some things were clearer. REBOA was barely used outside of facilities with fewer than 3,000 trauma admissions a year. REBOA patients' average systolic was more than twice that of thoracotomy patients. If you had CPR, you're more likely to end up with a thoracotomy. If you had a REBOA done, you are far more likely to have aortic occlusion done by a surgeon than an EM physician. If you took longer to get to the hospital, you're probably going to get REBOA instead of a thoracotomy. You are more likely to live if you had a REBOA placed. If you did die after having a REBOA placed, you're much more likely to die in the ICU. But if you had a thoracotomy and died, it was going to be right there in the ED. Mortality was lower in the REBOA group. These relationships were all true even after propensity score matching, but I kind of don't care about that as much as I care about the fact that when propensity score matching was used, the N went from 991 to 112. It's really difficult to see that and not conclude that REBOA was being used for massively different patients than resuscitative thoracotomy by different physicians in different kinds of institutions. I'm more confident in that statement than I am by any finding in this article. Remember when I said that REBOA just needed femoral access? The assumption was initially that the lower threshold for REBOA resulted from the speed and ease of deployment compared to thoracotomy. So why did the REBOA group need 21 minutes to get successful aortic occlusion compared to 12 for thoracotomy? Well, a retrospective analysis of both thoracotomy and REBOA at shock found that the average time to aortic cross-clamping was 317 seconds, and the time to zone 1 REBOA inflation was 474 seconds. The rate-limiting step appeared to be femoral arterial access, though. If arterial access had been obtained, the time to occlusion with REBOA dropped by almost half and was quicker than thoracotomy. At this point, I want to remind you that 31 years before this paper, Lowe's group in Oklahoma had started putting in prophylactic femoral lines for exactly this reason. Now, among REBOA patients, it took twice as long to get arterial access in patients in arrest than in hypotensive patients, which is surprising to nobody. Percutaneous access was successful 87% of the time as long as there was a blood pressure. If the patient was arresting, success rate dropped to 14%. With that information about access, hypotension, and arrest, let's go back and look at the aorta registry data again. Patients who got REBOA were less often in arrest than those who got thoracotomies. When they weren't in arrest, they still had higher blood pressures than patients who got resuscitated with thoracotomy. Attending surgeons performed more than 93% of REBOA. Nearly half of the thoracotomies were done by non-attending surgeons, whether they're fellows, residents, or ED doctors. Patient who underwent REBOA is more likely to be at a high-volume trauma center. The aortic occlusion is more likely to be done by an attending surgeon. They're going to be far less likely to be in arrest, and if they're not in arrest, they're not going to be as hypotensive. REBOA is happening earlier in the patient's decompensation than a thoracotomy. Maybe because the operators know that it's going to be much harder to get access later. Maybe because psychologically it doesn't seem like as dramatic a move. The point is that if the setting is different, high-volume REBOA centers, low volume, the patient characteristics are different, and the treating personnel are different. None of the papers I've mentioned so far are actually comparing a REBOA catheter with an aortic cross clamp. They're comparing different systems of care, which leads us here. The UK REBOA trial, published a couple months ago in JAMA, so we can all look forward to rheumatologists having very strong opinions about hemorrhage control. The UK REBOA trial was a prospective randomized trial conducted at 16 major trauma centers in England. Inclusion criteria were age over 16 and confirmed or suspected life-threatening torso hemorrhage thought to be amenable to REBOA. There were no hard criteria regarding hemodynamics, mechanism, laboratory studies, or imaging results. The only criterion was a doctor deciding that the patient was probably had torso hemorrhage that was appropriate for REBOA, at which time the patient was randomized. If the patient was randomized to the REBOA group, they were allowed to have a REBOA placed if the clinician decided to do so. The clinician was also empowered not to do so, but the patient would still be in the REBOA group. If the patient was randomized to the standard care group, they would be given unspecified standard care that would not include REBOA and was not otherwise documented. The primary outcome was 90-day mortality. The trial ran for 53 months, and in that time, 90 patients were randomized. It was stopped early because of calculated harm. Here's the headline first. At 90 days, 54% of the REBOA group was dead, compared to 42% of the standard care for an odds ratio of 1.58. But let's look at this more closely. Of the 46 patients randomized to REBOA, only 19 actually had the REBOA placed and inflated. That's less than half the patients in the treatment group undergoing, the treatment. What happened to the other patients? 9 got arterial access, but they never put the balloon in because the patient improved. 5 got access. The balloon was placed, but it wasn't inflated because the patient improved. In 8 patients, they just couldn't get arterial access at all and then just stopped trying. In 3, they just didn't even attempt arterial access because the patient improved. And in 2, they didn't attempt arterial access because the patient deteriorated, which I presume meant that they died. Naturally, of the 44 patients who were randomized to standard care, 2, that's almost 5% of them, got a REBOA inserted and inflated. The study took place over 53 months among 16 centers. That means that each hospital enrolled 1 patient every 10 months. That also means that each hospital enrolled 1 patient for the REBOA arm every 20 months. Of course, things weren't equally distributed. The busiest center accounted for 20% of all their patients in the REBOA group, and that center enrolled all of 9 patients. That's 1 patient every 6 months in the busiest REBOA center in the trial. That's not per physician, by the way, that's per center. This hasn't been published, but from personal communication, I can tell you that 1 physician in the study had put in 2 REBOAs over the course of the trial. Everyone else had put in 1. That's not counting their experience prior to the trial, of course, which, by the way, was utterly non-existent. All the physicians were trained on simulators and cadavers upon center enrollment in a 2-day course that was later shortened to 1 day. So these physicians learned how to use REBOA on cadavers and simulators. And with the exception of 1 doctor, the only REBOA they entered into the trial was the first one they'd ever put into a living person. They were also, by the way, expected to facilitate the development of a local REBOA service. So we can take as given that none of these trauma centers had established protocols to integrate REBOA within the care pathways. A couple of other things leap out here. Of the 90 total patients enrolled in the trial, 13 died within 3 hours, and by 24 hours, 27 patients were dead. That's a 30% overall mortality. At 90 days, 48% of the patients were dead. It again raises the question, are the patients who were chosen for this study, remember, the sole criterion for randomization was that the physician thought the patient was bleeding in the torso and it was a situation appropriate for REBOA. Are the patients who were chosen for this study moribund? To the enrolled physicians, was the indication of REBOA, these patients are going to die? These patients had a median ISS, by the way, for the thorax of 4. It was the most severely injured region in both groups. It is, incidentally, generally agreed upon that Zone 1 REBOA is inadvisable in patients with thoracic vascular injury for reasons that should be obvious. One of the things that is really inconsistent with both the observed mortality of both groups, as well as the idea that they were randomized because they were doomed, is that only a third of them underwent any kind of definitive hemorrhage control, laparotomy, extremity vascular repair, angioembolization, anything to actually stop the bleeding. And no, that isn't because everyone else just died before they could get to the operating room. When they did go to the operating room, they went between an hour and a half and an hour later. Fewer of the REBOA group patients went for definitive hemorrhage control, and those that did go went 20 minutes later than standard care patients. So let's imagine the typical patient in their course. They sustain blunt trauma and are taken to a trauma center. They're hypotensive, they're tachycardic, the emergency physician randomizes the patient to the REBOA group. They're excited, the doctor is, because they've never placed a REBOA in a live human. This patient is extraordinarily lucky because the doctor actually successfully gets arterial access, puts the catheter in, and deploys the balloon. Hooray! They now either get better and the balloon is taken out, or else they wait an hour and a half to go to the OR. The study doesn't mention it, but I really hope that REBOA isn't up for the entire hour and a half they're waiting. Remember, animal and later human data places an upper safe limit of a half hour on Zone 1 occlusion. Anyway, regardless of whether they were in the REBOA group or not, there's a 30% chance that that patient will be dead in a day. Maybe it is because the patient waited a half an hour to get any kind of resuscitation. It might be the hour and a half they waited to get any kind of definitive hemorrhage control. It might be because they didn't get any definitive hemorrhage control. We don't know. It would be wrong of me to say that this study doesn't say anything. It does say something. It says that if you send an ED physician to a one-day training course and tell them that they're allowed to put in a REBOA unsupervised whenever they happen to think it appropriate, they're probably going to do more harm than good to the first patient they consider for REBOA, even if they don't actually put up the balloon. It says that if that physician does this in an institution that has never before done REBOA, they're probably going to do more harm than good. And it says that if those institutions don't even think about REBOA more than once a year, they're probably going to do more harm than good. For the next 2 to 3 years, whenever REBOA comes up, someone is going to talk about this study. And when they do, all they will remember is that REBOA increases mortality. So am I a REBOA advocate? Sure, absolutely, for me. I've put in maybe 50 or so. I'm in a center that in the summer puts one in every 10 days. A zone 1 usually goes up only when a patient's peri-arrest or in arrest, and a zone 3 after a couple of units of whole blood don't fix things and when there's a pelvic fracture. When a REBOA goes up, the patient is in the hybrid room for embolization or the regular OR for exploration in a half hour to 45 minutes, and all of them go for definitive hemorrhage control. There's always at least one attending trauma surgeon and one critical care attending in-house at all times, and both of them, all of our faculty knows how to work with REBOA. So if I want to run a true randomized controlled trial for REBOA, everything I said has to be replicated to be compared to our use. It's an instrument the effect of which is profoundly operator dependent, patient dependent, injury dependent, and system dependent. By way of comparison, or even context, a couple of years ago, a paper out of the aorta registry looked at REBOA outcomes in low, average, and high volume REBOA centers. They found that in high volume centers, REBOA patients had a lower systolic on presentation before the balloon went up. More of them were hypotensive, more of them were in arrest. High volume centers placed REBOA in the ED, low volume in the OR. In high volume centers, you are more likely to have the balloon placed by the attending trauma surgeon. In high volume centers, it took 15 minutes from admission to aortic occlusion. In low volume centers, it took 35 minutes. Mortality at high volume centers was 75% of that in low volume centers. REBOA was more successful with sicker patients than it was at a high volume center. Different systems, different physicians placing them, different patients, what looks to be different indications. I said when I started that REBOA was an instrument, I didn't see what the fuss was about. Well, we've seen that it's actually not that. I was completely wrong. It's not a cryo clamp at all. It requires a lot of individual expertise and experience to use the thing, not because it's technically difficult, but because it's clear that what makes a patient appropriate for REBOA is operator and institution dependent. It requires an institutional commitment insofar as you don't just need REBOA competent surgeons, but REBOA competent nurses, anesthesiologists, CRNAs, intensivists. You need people who understand what a REBOA patient is going to act like after 48 hours or 72 hours or intraoperatively. How can we think about REBOA then when we want to understand how to evaluate it? How do we talk about it? What do we talk about when we talk about REBOA? Don't read too much into this. I'm not offering transplant as a one-to-one allegory or even a faithful metaphor for REBOA, but I am saying that if we are trying to conceive of REBOA in a way that's both comprehensible and practical, thinking about it the way we think about transplant, rather than the way we think about thoracotomy or hemostat, might be helpful. And in that spirit of REBOA being a collaborative effort, and in this context today, I want to specifically talk about the experience of our anesthesiologists. The patients discussed in this paper came between 2013 and 2016, but it's worth talking about the kind of patients we're dealing with, us specifically in shock, and I imagine the same patients you're getting there. The cases are starting with a pH of less than 7.1, the temperature is less than 34, and the lactate is 9.5. The surgeries took about 2 hours, and the patients only got 2 liters of crystalloid. They got 24 units of blood products, though. Now I ask you, do you think that the patients getting REBOA at most other hospitals are this sick? Do you think they're getting the anesthesia resuscitation shown here? I'm on, as I mentioned, monthly conferences with other centers, and I can promise you that they're not. Intraoperatively, REBOA is absolutely a joint effort between anesthesia and surgery, far more than an open aortic clamp. When you physically unclamp an aorta, it's an event, it's announced, everyone prepares, most of us hold our breath. The ease of inflation and deflation, I fear, has inhibited this communication. It's so easy for the surgeon to look at the monitor and maybe just deflate a little bit and see what happens. Maybe a little more. There's no need to let anesthesia know, right? Same way anesthesia can just give a little bump of neo and not tell us. And for your part, if the patient starts to drop their pressure 10 minutes after the balloon's deflated, maybe you just touch them a little. No need to ask for reinflation, right? I'm not criticizing anyone, or I'm criticizing everyone, myself included. The interplay between the concerns on both sides of the curtain is complex, and it's on a time delay because you don't see the effects of the deflation immediately. And when you add the effortlessness of aortic occlusion, there's a real danger in that lack of communication across the drape. I will close with this. I expect that most of you are familiar with Smith and Pell's systematic review of RCTs looking at the efficacy of parachutes. To nobody's surprise, they didn't find any trials and concluded that use of parachutes should be suspended pending resolution of equipoise. Fewer will have seen this, which is an actual randomized controlled trial comparing parachute use with none and finding no benefit. However, while the groups had been matched on things like a history of broken bones, acrophobia, a family history of parachute use, frequent flyer miles, they failed to control for two fairly important variables. As it turns out, the parachute group had an average altitude of about 9,000 meters and an average velocity of 800 kilometers an hour. The control group had an altitude of a couple of feet and a velocity of 0. Different contexts, different conditions, and different subjects. Fewer among you still will know this, which is an analysis of articles that use the parachute metaphor. I'm including this just because I thought this was a very witty article to have thought of and written. You can see that the metaphor was most often used to conclude that some unproven intervention should use without RCTs due to common sense, and that's not what I'm claiming for REBOA. I'm claiming that an RCT should take into account all of the factors that affect REBOA efficacy, and in the meantime, its use in a specific hospital, in a specific patient, on a specific day, has to depend on whether it makes sense to you. So we have to be confident, decisive, and rational in the absence of sufficient data, which is in trauma what we're doing anyway. All right, that's it.
Awesome. Well, thank you very much. And thank you for coming on and being passionate about this. And I would say making us look at this just in a different way rather than what I agree. We kind of hear just results of studies and say it's not effective. I know we have a bunch of surgeons on. I'm curious what other people's opinions are, especially from WashU, but also from outside of WashU, in terms of REBOA use. Nobody else wants to step up and give an opinion on this. Sure.
Rishi, can I?
There we go.
Rishi, it's Raj from Harborview over in Seattle. Thank you so much for your talk. And yes, as you can hear, I'm British, and I was in the UK REBOA trial when it started. I was on one of those sites that was trying to recruit, and can remember going through the training for that. And since then, I've been over at Harborview, and really, we don't use any REBOA apart from in semi-elective or even urgent vascular surgery, but really it's vascular surgery where we're using it. And so, and we also don't have that many vascular surgeons who are part of our trauma teams. So if we are to look at this patient group where you're seeing benefit or potential benefit, how do you go about building that team?
That is a question that's really hard for me to answer because the team was already building when I got here, and the reason that I came here was essentially because of that enthusiasm. I think that vascular surgeons are going to be involved at one stage or another because they will have to deal with the access problems, right? It's the same thing as like the cath lab problems. Vascular surgery is involved in coronary catheterization because they get called when something goes wrong with the access site. Aside from that, I don't think you need to be a vascular surgeon to be adept with REBOA. I've actually taken some of our critical care attendings through the BEST course. I've watched as they've deployed it. Certainly in our fellowship program, we have emergency medicine critical care fellows who become very familiar with REBOA use. I don't think it's a vascular surgery thing at all. I think that it's developing enough experience and familiarity with it that you achieve and this is going to sound very woo-woo, a personal understanding of how useful REBOA can be in your patient in front of you. It really is kind of a feeling. And that feeling is entirely context dependent. Coming into Harborview, if you don't use REBOA a lot, and I show up and I start doing it all over the place, I'm going to have a terrible result. It's not gonna work because no one else is used to it and the system's not in place. So I guess how to build it, get a core group of trauma surgeons. I would absolutely bring anesthesiologists in it. I would bring critical care people in it and have an express interest in this. And then rather than roll it out throughout the center all at once, it can be something that's just available to those physicians who are on call. And when they see a patient who it might work with, they use it. I think that's really it. I think rolling it out on an institution-wide basis is probably not going to be that effective. I think doing it with a small core group of people who are able to use it when they are on call, and when they do use it to monitor and kind of shepherd the patient's care throughout, that is how you're going to start to build momentum. Justin, would you agree?
Completely. So my question for you, and admittedly missed the beginning, and if this was covered, I apologize, but I'm continuously asking this question as we learn more about the utilization of it. But your thoughts, blunt versus penetrating, utility of REBOA potentially in penetrating, and then time, duration at which it can be left up. Because again, you were talking about zone 1 REBOA, at least the patients who are getting zone 1, but I think the utility in a lot of this is for pelvic fractures. And what is the time frame that at least we are kind of thinking about for which this can be left up? I think that kind of has evolved over time too.
I think for penetrating trauma, I am very apprehensive about using it and thinking that it provides any kind of security against ongoing hemorrhage. Those patients need to be in the OR. The exception being if a patient is we've used it with there was a fad in Baltimore a couple of summers ago. I'm sure you remember about transpelvic GSWs that took out iliacs. We've used that in at least 3 or 4 patients to good effect. That was very daring, and I certainly wouldn't advocate that, as a neophyte to REBOA. But other than that, for penetrating when they're peri-arrest, but in those patients, if they've exsanguinated to the point where they're peri-arrest, then I'm not sure that zone 1 is really going to add anything. And if they've got thoracic injuries, that's a reason to open the chest. So I'm definitely a little hesitant about penetrating trauma. I'll use it, but not with the same readiness and enthusiasm that I will for blunt. And as for the duration of zone 3, it's an open question. I think if it's up for more than an hour, I start to get nervous, not about compartment syndrome necessarily, but about thrombosis. These are patients who, when you take out the aortoiliac junction, you're taking out the vast majority of the collaterals. I think at that point, the only thing that is providing any kind of perfusion is going to be through the epigastrics and the common femorals. And that's not going to be enough to prevent thrombus formation in the legs.
That was going to be my other question, which you kind of answered, I think, at least. But in how many of these people if you're doing zone 3, do we need to be thinking about empiric fasciotomies because of compartment syndrome? Especially with then I think the risk of kidney injury that goes on top of it.
Yeah. It doesn't take me long in a patient who's critically ill, who's had, if it's like anything else, it's not just how long are you occluding the aorta, it's how hypotensive are they, how sick overall are they, how many bad humors do they have running through their system from other means. It wouldn't take much for me to do prophylactic fasciotomies in those patients. And it is January 29th, Justin. It is time to take down that Christmas tree.
It's a long story.
Mm-hmm. Yeah. All right.
Well, so I guess the other part is most people probably will get the laugh to this, but maybe if they're so acidemic, we should just give them bicarb.
Oh,
So to
why
tell everyone else this, a couple of weeks ago, maybe last week, I asked Justin a simple question. I said, Justin, because he was railing against giving bicarb for patients, and I said, in arrest, I said, Justin, I seem to vaguely remember something about like catecholamines and adrenergic medications being much less effective under a pH of 7.2. And he said, no, that's hogwash. That's complete garbage. So I threw some papers at him, and I have yet to actually get a response from him. Is now going to be when you
I'll
kind of
post one. You want to
But you're
respond?
not going to
I'll
win
do
this
one.
battle now with this crowd.
that came out of a place of genuine curiosity.
No, thank you so much for doing this. This is Justin, to you too. Thanks for letting us participate. This is a great resource to have. I'm glad to get to be a part of it for all of us.
Absolutely. No, I appreciate it. And I did hear of two future talks in this. A partial REBOA talk. I think I got a volunteer on that. And Justin, I think you just volunteered to give one on bicarb, which I will back you
Oh,
every step of the way. If there was a pro con, I would love it.
That'd be a
a-
great idea. Actually, a pro con.
If there's I'd love to do one, especially on that. And that's one of my, loves is to talk about bicarb. So if we can put that together, I would love to. Justin, if you want to take one side, I will find you a combatant. So
I actually
I'll
have
volunteer for it.
I have a question actually. Raj, I would not at all be surprised if Ben Starnes were somewhat receptive to a REBOA program. And I was gonna say Elena Quiroga, but she's in Oregon now, isn't she?
No, they're both with us.
Okay.
I think the minor difficulty is that they're not on the activating trauma team, right? So they're not there when the patient arrives. They are on the vascular service.
Yeah.
And I think the other side of it is the thoracic and the trauma surgeons are very good at getting early proximal control. So it's that time differential between getting femoral access and getting the REBOA in versus how quick they can get proximal control and get the patient in the OR.
I mean, I don't think REBOA is necessary, and I don't think it's a panacea. It's just kind of a useful technique, and I kind of wish people would stop making such a big deal about it one way or the other.
I have a question about REBOA. If you can hear me. So
I
sorry,
can.
this is a vague question, but like some of us work at some of these outside hospitals that are very, very small where we don't have all the resources of these big level 1 trauma centers. And some of these places, I think REBOA sounds like a great idea in some of them, but like getting the whole hospital or like even getting a small group of people behind it, I think is you really have to kind of push. And I was talking with your talk coming up, I had one of my other program directors, and she and I are both trained in REBOA. I think she's even a best instructor, but we're both toying with the idea of what is the value in pushing so hard for a hospital that doesn't have 24-hour IR coverage, doesn't have a huge blood bank. The best thing we can usually do for people is stop bleeding as best possible and transport. Like, is there value in doing REBOA or pushing to do REBOA at some of these smaller facilities where it's going to be is it worth it to even push that hard to get it there?
I think it is. We have had a couple of cases, in fact, where we have gone out to smaller hospitals to deploy a REBOA and then bring the patient back. If you're going to do it, I would approach it in partnership with your designated trauma center that you transfer patients to. And you could say, hey, we send you these patients, and I wouldn't do it for zone 1. I think zone 1 is not the way to go. But if we have hemodynamically unstable pelvic fracture patients, we think that it would be useful if we established a pathway where we deployed a REBOA temporizing and then transported the patient to you. Because I think then you would get, if they are a center that does a lot of REBOA, you would get their expertise, and by expertise, I mean infrastructure expertise, to help you develop it at your center. And it's, to be honest, going to be an easier sell at a hospital that might be a little, reticent or apprehensive about it, to say, we want to bring this in as an adjunct to transfer rather than something that we're going to do here. Does that make sense?
Yeah, absolutely. She and I were kind of talking about it today, and she's already been getting questions about whether or not she will be using it in OB trauma, or not OB trauma, but OB bleeds as well, because that's kind of the other big question she's starting to get, as far as like if we should push for REBOA there or not.
Do you guys do a lot of
Like,
placenta accreta spectrum?
no, it's a very small hospital. It's just kind of those, one-off emergency cases where they can't control bleeding. It's kind of one of those
I think
emergency.
I think it's a great thing to have available and have at least a couple of people who know how to use it. Particularly for OB bleeds, because those are not bleeds that are easily surgically controllable. And there's an obstetrician gynecologist in Texas by the last name of Cohen who has made this has come up with some really convincing evidence for its use, both emergently. We do it a lot semi-prophylactically here for placenta accreta, but I think that it has real utility in OB patients.
I think it almost goes back to the point that we were talking about before the conference about, the tools and using them, and how, you brought up the example of the place that uses it because they don't have a lot of blood. And, just having another tool in your tool belt to use, and something that may prove beneficial in certain patients, why not at least know how to do it? There are a couple more questions. One of our ED docs, Chris Holthouse, she's still on. I think you emailed me, you had a question or texted me.
Yeah, thanks. Rishi, phenomenal talk, by the way. Thank you so much.
Thank
for
you.
Comprehensive overlook. So you hinted at a little bit earlier when you were talking about sepsis and mods, and just like talking about 20 to 30-year-old studies, Kumar's in 2006, which showed the mortality increase for sepsis antibiotic delays with shock of 7.6% per hour for delayed antibiotics. The kind of question is, with intestinal ischemia, bacterial translocation, blood cultures being poor in general, even and when they're febrile and shocky, only 30 to 50% positivity. It's a hard thing to diagnose, but I was just kind of curious, in the realm of all of this, how much of a factor do you think that is as at least a secondary insult with gut hypoperfusion? And then how prevalent is it that people are really covering enteric pathogens amidst this? And I wonder, as a confounding factor, even if you looked at ones that empirically got it up front, right at the get-go, versus delays to it that were preventing secondary insults, or even, there's a lot of confounding too with the gut ischemia times that you alluded to, that just becomes an angry beast when you let that down, and all the inflammatory release after that. But I just want to know, in your guys' experience too, is enteric coverage like an empiric thing you do up front, later, wait for it? Like, where in the realm is that for your centers and other places, and even in the literature for REBOA?
We don't do empiric coverage, but after listening to that extremely thoroughly backgrounded question, I think it makes sense, right? I can't cite the papers offhand, but I think that it's been well established that the longer that someone is hypotensive, the greater the chance that they will have not only organ failure, but infectious complications after resuscitation, after definitive management, or hemorrhage control rather. So it probably does make a lot of sense, if you pass a certain point of hypoperfusion, to start some kind of empiric antibiotics. We don't do it, but it's one of those things that I think intuitively is not ridiculous at all.
Gotcha. Yeah, I run our sepsis committee for the hospital and ED, but we were interesting looking at patients that didn't get antibiotics, and they had lower mortalities when they didn't even end up with a sepsis diagnosis, that got antibiotics off a hypotensive alert. So it's an exploratory idea, a couple percent lower. And I was just kind of curious that the body doesn't care what the primary shock etiology is, but once the gut gets injury and a problem, you're dealing with the aftermath after that. And so it's almost begets like how we do pre-op antibiotics for surgeries to prevent skin and soft tissue infections. Could there be some potential role? This could be somebody's whole career if you could prove this, I guess, that hypotensive NOS starts and then it kicks in, and could be a role for empiric antibiotic prophylaxis to prevent,
I mean, that honestly, that would be a pretty
ischemia.
simple multi-center trial. You just have to define some length of time of hypotension, and just give like a single dose of Flagyl or and yeah,
Yeah, but thanks for that talk. It was fascinating. Appreciate it.
thank you for the idea. That's great. Anyone else?
We are another center, so if we want to put some multi-center trial together, that's it's a possibility. All right. I'm not seeing anything else in the chat. So I'll say fantastic talk. Thank you so much. It was
course.
wonderful. Loved hearing it. We'll be in touch about the partial talk at some point. Maybe next year. But
That
yeah.
would-
Yeah, thank you so much. Again, we'll have this up on YouTube hopefully by the end of the week. And with that, I'll see you guys next month. I'll send out the email in a little bit for the invite for next month. I think it's February 26th, I believe. So yeah, thank you guys. Have a good night.
All right. Good night.